All right, let's jump into this deep dive today, focusing on those pesky nerve compressions of the upper extremity. Super relevant stuff you'll definitely need for your surgical boards.
Absolutely. Can't escape those.
We're going to cover all the need-to-know anatomy, the physiology behind how these nerves get squeezed, how to recognize the symptoms and nail the diagnosis, and then, of course, what you need to know about treatment for the median, radial, and ulnar nerves.
Sounds good.
So why don't we kick things off with the median nerve, probably the one we see the most. Where do we even begin with this one?
Well, you really have to have a solid grasp of its anatomy, where it runs, what it's close to. I mean, that's going to dictate everything else, really.
Right, of course, the foundation.
So it all starts with the brachial plexus.
Hmm.
From there, the median nerve journeys down the arm, passing right by the brachialis muscle and that medial intermuscular septum. It hangs out pretty close to the brachial artery, too. And just as a heads up, there's this thing called the ligament of Struthers near the elbow that can sometimes cause some trouble.
Ah, yeah, I remember that one from anatomy. Not always present, but can definitely be a pain when it is.
Exactly.
So then what? It keeps going down into the forearm.
Yep, it heads right under the bicipital aponeurosis, which some people call the lacertus fibrosus. Then it kind of weaves its way between the two heads of the pronator teres muscle. And oh, this is important. This is where the anterior interosseous nerve decides to branch off. It goes on to run along the front of those forearm bones. Right on. And the median nerve, where does it end up?
Well, it keeps on trucking between the flexor digitorum profundus, the FDP, and the flexor pollicis longus, the FPL.
Lots of long names to remember.
I know, right? And finally, it goes under the flexor digitorum superficialis arch, the FDS arch, before it makes its grand entrance into the carpal tunnel.
Okay, so before we get to the infamous carpal tunnel, anything else we need to know along the way?
Oh yeah, almost forgot. The palmar cutaneous branch actually branches off about 5 centimeters before the tunnel. That little guy is responsible for sensation to the thunar eminence.
Makes sense why that area is usually spared in carpal tunnel syndrome then. Good to keep in mind.
Exactly.
Okay, so the carpal tunnel. What makes this such a prime spot for compression?
Well, picture this. You've got the carpal bones forming the floor, and this tough band, the transverse carpal ligament, making the roof. It's a pretty tight space, and it's packed with not only the median nerve, but 9 tendons as well.
9 tendons. Which ones?
You've got the flexor pollicis longus, the FPL, 4 flexor digitorum superficialis tendons, and 4 flexor digitorum profundus tendons.
Wow, that is a lot crammed in there. No wonder things can get compressed. And isn't there something about variations in the median recurrent motor nerve, too?
Oh, you're right. That's crucial, especially for surgeons. That nerve, which supplies those thenar muscles, can take a few different paths as it branches off. It might go above, below, or even right through that transverse carpal ligament. You definitely don't want to be surprised during surgery.
Yeah, that could be a real nightmare. Avoiding injury there is key. Okay, so before we move on to carpal tunnel syndrome itself, what about the anterior interosseous nerve and what the median nerve does in the hand?
Right, so the anterior interosseous nerve, that one innervates the radial half of the FDP, specifically for the index and middle fingers. It also takes care of the FPL and the pronator quadratus, plus some of the wrist and carpal joints.
In the median nerve itself.
That one innervates the rest of the phenol muscles, the abductor pollicis brevis, opponens pollicis, and the superficial head of flexor pollicis brevis. Plus, it handles the lumbricals for the index and middle fingers.
Okay, got it. So all this anatomy is super important because, like you said, it sets the stage for understanding how things go wrong, like carpal tunnel syndrome, CTS. It's like the poster child for nerve compression in the upper extremity.
Oh yeah, definitely up there in terms of frequency.
So what's the classic presentation for CTS? What are patients telling you?
Well, they usually come in complaining of pain, especially at night. And then there's numbness, that tingly feeling in the palm side of the hand. It usually affects the thumb, index, middle, and part of the ring finger.
But the thenar eminence is usually okay, right? Because of that palmar cutaneous branch we talked about.
That's right. And then using their hands a lot, doing repetitive motions, that tends to make things worse. And in more severe cases, you might even see some wasting of the thenar muscles.
And on exam, what are you finding?
We'll often notice decreased light touch sensation in that median nerve territory. Weakness in thumb opposition is a big one, but interestingly, their thumb IP joint flexion is still normal.
So if you suspect CTS, what's the next step?
Nerve conduction studies, or NCS, are your best friend here. If you see a motor latency over 4.5 milliseconds and a sensory latency above 3.5 milliseconds, that's a pretty good indicator.
What about in kids? Does it present differently?
It often does. They more commonly present with the thenar atrophy, and it's often bilateral.
Interesting. Anything else we should be aware of?
Oh, there's also this thing where the lumbrical muscles can sometimes herniate into the carpal tunnel.
Really?
Yeah, it's not super common, but it can happen and contribute to that increased pressure in there.
Hmm. Worth keeping in mind.
Yeah.
So once you've made the diagnosis, how do you go about treating CTS?
First line is usually non-surgical. We try things like wrist splints to keep that wrist nice and straight, especially at night. We'll also talk to them about modifying activities that seem to be aggravating their symptoms.
Right, makes sense. And medications?
NSAIs can help with pain and inflammation.
Hmm.
And then there are corticosteroid injections into the carpal tunnel.
Do those injections usually work?
They can be pretty effective, especially if the NCS show mild involvement and if the symptoms haven't been going on for too long.
Got it. So what if all that fails? When is surgery on the table?
Well, if those conservative measures don't do the trick, then we start thinking about surgical release of the transverse carpal ligament.
And what does that involve?
So, in an open release, you're making an incision and directly cutting that ligament to free up space. And just to clarify, we don't usually do routine neurolysis, epineuridomy, or flexor tenosynovectomy during the procedure.
Okay, good to know. And what kind of recovery can patients expect?
Well, they usually start feeling some sensory improvement within a few weeks. Nerve conduction velocities tend to get better around the 3-month mark, and strength gradually comes back over about 6 months.
But I imagine regaining full strength in the thenar muscles can take a bit longer if there was atrophy.
Absolutely. It can definitely take more time. And if someone's still having symptoms after surgery, we have to consider a re-exploration to see what's going on.
That makes sense. Any common complications with open release?
A sensitive scar in the palm is something we see fairly often. Open release does let you see everything clearly and make sure that ligament is completely divided. It even lets you take care of Guyon's canal at the same time if needed.
Right, so it's a pretty versatile approach.
Yeah, but that bigger incision can sometimes mean more scar tenderness. That's where endoscopic release comes in.
Right, I was just going to ask about that. What are the pros and cons there?
Well, the big plus is a smaller scar, and patients can often get back to their normal activities a bit faster.
But there's got to be a trade-off.
Yeah, there are a few things to consider. There's a slightly higher chance of accidentally nicking the nerve, not fully releasing the ligament, and even having the CTS come back because of scar tissue or tendon inflammation.
Okay, so both approaches have their place. And no matter which way you go, that median recurrent motor nerve is something you always have to be mindful of.
Absolutely. Protecting that nerve is paramount.
All right, so we've covered carpal tunnel syndrome. What's next on the median nerve hit list?
Let's move up the forearm a bit and talk about pronator syndrome.
Okay, so with pronator syndrome, what's the typical story?
Patients typically describe pain in the proximal forearm, the part closer to the elbow, and that pain tends to shoot down towards the thenar eminence and those radial-sided fingers. They'll also mention paresthesia and numbness in that same distribution.
So similar distribution to CTS, but higher up. What about weakness? Is that as common in pronator syndrome?
Actually, motor weakness isn't usually as noticeable in pronator syndrome compared to CTS. That's one way to start distinguishing them.
Interesting. So if it's not the carpal tunnel, where else is that median nerve getting trapped?
Well, there are a few culprits. Sometimes it's that lacertus fibrosis we talked about earlier. Other times it's the pronator teres muscle itself squeezing the nerve between its two heads.
And those are the most common.
Yeah, those are the usual suspects. But it can also happen under the arch of the flexor digitorum superficialis. And then there are those less frequent cases where it's due to some anatomical anomaly, a blood vessel pressing on the nerve, or even that ligament of Struthers.
Okay, lots of possibilities.
Yeah.
How do you go about figuring out if it's pronator syndrome?
A lot of it is clinical, using provocative maneuvers to see if we can reproduce their symptoms.
What kind of maneuvers?
For example, we might tap directly over the pronator muscle and see if that triggers tingling. We'll also have them flex their elbow and pronate their forearm, or try resisting finger flexion If any of those make the thenar eminence tingle, that's a pretty good sign.
So you're trying to put pressure on the nerve and see if it recreates their symptoms.
Exactly. We might also find weakness of thumb IP and index DIP joint flexion, but nerve conduction studies aren't usually that helpful in diagnosing pronator syndrome.
And treatment.
If we're pretty sure it's pronator syndrome, we usually go straight to surgery to release whatever structure is causing the compression.
And those usually go well.
Yeah, outcomes are generally good.
All right, so we've tackled carpal tunnel and pronator syndrome. Anything else we need to know about the median nerve?
One more, and it's a bit of a tricky one, anterior interosseous syndrome.
Okay, tell me about it.
This one presents with a very specific loss of function. You'll see problems with the flexor pollicis longus, the FDP to the index and middle fingers, and the pronator quadratus. They can't do those movements properly.
So, specific motor deficits. What about sensation?
That's the interesting part. Sensation is totally normal in anterior interosseous syndrome.
That helps narrow things down. Where's the entrapment usually happening?
It's usually caught by the tendinous edge of either the deep head of the pronator teres or the origin of the flexor digitorum superficialis.
Got it. Any telltale signs on exam?
There's this classic sign called the pinch deformity. Basically, the index finger gets stuck in this weird position, extended at the DIP joint and overly flexed at the PIP joint. And of course, they'll have weak thumb IP flexion too.
Okay, I'll have to look out for that. Can NCS help with this one?
Definitely. They can help confirm the diagnosis.
And treatment. More surgery.
Usually, yeah. We'll do an anterior approach and carefully free up that nerve. Loop magnification can be a big help here.
Makes sense. All right, I think we've covered the median nerve pretty thoroughly. Let's shift gears to the radial nerve now.
Okay, on to the next one. So where does this one start?
It branches off as a terminal branch of the posterior cord of the brachial plexus.
And then it makes its way down the arm. How does that go?
It starts out behind both the axillary and brachial arteries, running between the heads of the triceps muscle. About 10 centimeters above the elbow joint, it passes through the lateral intermuscular septum with the radial collateral artery keeping it company. Then it travels between the brachialis muscle and the brachioradialis and ECRL muscles.
Okay, so it's got quite the journey. What about that radial tunnel? I remember that being a bit of a hot spot.
Oh yeah, the radial tunnel is another important spot. So picture this. The radiocapitellar bursa forms the floor. The brachioradialis tendon makes the roof. You've got the ECRL and ECRB tendons on the radial side, the biceps tendon on the ulnar side, and it all ends at the distal edge of the supinator muscle.
That's quite a few landmarks. Anything else we need to know about the radial nerves course?
Well, about a centimeter lateral to the biceps tendon and the cubital fossa, the radial nerve splits into two branches. The deep branch is called the posterior interosseous nerve, or PIN, and the other is the superficial radial nerve.
Okay, so two branches. What do they each do?
The PIN goes under this fibrous band called the arcata fros, which is part of the supinator muscle. Then it runs along with the extensor digitorum communis tendon. The PI innervates the EIP and EPL muscles and gives sensory input to the back of the wrist capsule. The superficial radial nerve is all about sensation. It supplies the back of the hand on the radial side.
So 4 potential compression sites around the elbow, with the arcata fros being the most common. What about radial tunnel syndrome? Does that sound familiar?
Yeah, it's basically when the PIN gets compressed in the radial tunnel. It can be a real pain to diagnose because it often looks a lot like lateral epicondylitis, tennis elbow.
Oh, I can see how that would be tricky. What are people complaining about?
Typically, they have elbow pain that travels down the forearm to the back of the hand. Sometimes there's tingling too, and they might have trouble gripping things because it hurts.
And what brings it on?
Doing the same motions over and over with the elbow, like extending and rotating it a lot, that seems to be a common culprit.
So how do you untangle radial tunnel syndrome from tennis elbow?
A radial nerve block can be really helpful here. It can tell you if it's the nerve causing the problem and give you an idea of how things might turn out.
So it's diagnostic and prognostic.
Exactly. There's also this thing called the middle finger test. You have them forcefully extend their middle finger with their elbow straight, and if it causes pain over the ECRB muscle, that can be a sign.
Clever. What about NCS? Any use here?
They're not as useful for radial tunnel syndrome, unfortunately. Sometimes injecting lidocaine right into the radial tunnel can give temporary relief and confirm the diagnosis.
Okay, so if you're thinking radial tunnel syndrome, what's the first step?
We almost always start with conservative treatment and NSAIDs. Rest, maybe a splint to keep the elbow still, and avoiding those repetitive movements that trigger it. Surgery is really a last resort.
And if you do operate, what's involved?
We'll surgically release the radial tunnel to free up that nerve, The problem is the results can be a bit hit or miss.
Okay, so conservative management first. What about posterior interosseous nerve syndrome, PIN syndrome? What's that all about?
So this one is more about weakness than pain. People have trouble extending their fingers and wrists, but they don't have any numbness.
Interesting. So what causes that?
A few things. It could be from an injury, bleeding around the nerve, inflammation from rheumatoid arthritis, soft tissue masses pushing on the nerve, or even traction injuries to the nerve.
So how do you get to the bottom of it?
We might start with an X-ray to rule out any problems with the radial head. Then, NCS can help check nerve function. If we think there might be a mass, ultrasound can be helpful. And if we need to plan surgery, MRI is usually the best bet.
And how do you treat it?
Well, it depends. We often start with conservative treatment, just like with radial tunnel syndrome. So rest in a splint for a few months. If it's related to rheumatoid arthritis, we might try corticosteroid injections, but we have to be careful with those.
If that doesn't work.
Then we'll consider surgery to release the nerve. There are a few spots where it can get compressed: the radiocapitellar fascia, the leash of Henry, the edge of the ECRB muscle, and the arcade of Fros.
Wow, quite a few places.
Yeah, and we can approach it from either the front or the back of the forearm.
Okay, so on to the last one, the ulnar nerve. Where does this one begin its journey?
It branches off as a terminal branch of the medial cord of the brachial plexus,
And then it travels.
medially and posteriorly to the brachial artery in the upper arm, then through the medial intramuscular septum around the middle of the arm. About 8 centimeters above the medial epicondyle, there's this fascial band, the arcade of Struthers, that covers it. It then goes behind the medial head of the triceps muscle and behind the medial epicondyle of the humerus, and that's where it enters the cubital tunnel.
Okay, cubital tunnel, what are its borders?
Medially, it's the medial epicondyle, laterally the olecranon. The floor is the FCU muscle and the ligament of Osborn, and the roof is made up of the joint capsule and the medial collateral ligament of the elbow.
So once it's out of the cubital tunnel, where does it go?
It runs between the two heads of the FCU muscle, which it supplies. Then it goes down the forearm between the FTP and FDS muscles.
And ultimately ends up in Guyon's canal.
That's right. It travels radial to the FCU tendon and ulnar to the hook of the hamate to enter Guyon's canal at the wrist.
Guyon's canal, another potential compression site. Tell me about it.
It's this passageway at the wrist. Proximally is bordered by the volar carpal ligament and distally by the pisiform. The roof is the volar carpal ligament. The ulnar border is the pisiform, FCU tendon, pisohamate ligament, and abductor digiti minimi muscle. The radial border is the hook of the hamate, and the floor is made up of the transverse carpal ligament and the hypothenar muscles.
That's quite a detailed description. And which muscles does the ulnar nerve supply?
A bunch. The palmaris brevis, all the interosseous muscles of the hand, the lumbricals to the ring and little fingers, the adductor pollicis, the deep head of the flexor pollicis brevis, and all the hypothenar muscles.
Wow, it's got its work cut out for it. What's the clinical significance of ulnar nerve palsy then?
Well, if the ulnar nerve isn't working, they won't be able to abduct or adduct their middle finger when it's straight. They also won't be able to cross their index and middle fingers.
Interesting. So let's talk about cubital tunnel syndrome. What are people experiencing with this?
Typically, it's tingling and pain along the ulnar side of the forearm, radiating down to the ulnar half of the ring finger and the whole little finger. It often extends to the back of the hand on the ulnar side too. They might also have weakness and muscle wasting in the intrinsic muscles of the hand.
And what's causing that compression?
It could be tight bands of tissue, tumors, trauma to the elbow, the nerve slipping out of place over the medial epicondyle, or even just variations in the anatomy of the cubital tunnel itself.
So how do you diagnose cubital tunnel syndrome?
We'll do some provocative tests, tapping or pressing on the cubital tunnel to see if we can bring on the symptoms. We'll also have them hold their elbow bent for a bit. If the nerve is compressed, that'll usually cause symptoms.
What are some of the late signs of cubital tunnel syndrome?
Well, there's Froment's sign, where they have trouble pinching because of weakness in the thumb. And then there's clawing of the ring and little fingers.
And NCS, can those help?
They can, but they're not always perfect. Sometimes they come back normal, even if there is a problem.
Got it. So what else are you looking for on exam?
Decreased sensation in the ulnar nerve distribution, weak DIP flexion of the little finger because of FDP weakness, and any weakness or wasting of those intrinsic hand muscles.
And how do you treat it?
If it's not too severe, we'll try conservative treatment first. Splinting the elbow at about 30 degrees of flexion, especially at night, can help.
And if that doesn't work?
Then we'll think about surgery to decompress the nerve. There are a couple of approaches we can use, either from the medial side or from the posterior medial side. The important thing is to find and protect those medial antebrachial cutaneous nerves.
So during surgery, what do you do?
There are a few spots where the nerve can get compressed, so we have to address those. Sometimes we can just free up the nerve where it is, or we might do a medial epicondylectomy. Or we can move the nerve to a different spot entirely, which is called transposition.
So there are a few options.
Yeah, we can do a subcutaneous, intramuscular, or submuscular transposition.
And which one do you choose?
It really depends on the individual case.
Hmm.
And to be honest, the results of cubital tunnel surgery can be a bit unpredictable. For cases that come back, we often do a submuscular transposition,
Okay, so that's cubital tunnel syndrome. What about ulnar tunnel syndrome?
also known as Guillen's canal syndrome. This one usually causes wrist pain, along with numbness, tingling, and burning in the little finger and the ulnar side of the ring finger.
And you mentioned zones of compression earlier. What are those again?
Right, so there are three zones within Guillen's canal. In zone 1, both the motor and sensory branches of the ulnar nerve are affected. Zone 2 is mainly about the deep motor branch, so you get weakness in those intrinsic hand muscles. And zone 3 is mainly sensory, so you just get those sensory symptoms in the fingers.
Makes sense. So what kinds of things cause ulnar tunnel syndrome?
You can get ganglion cysts near the wrist, occupational trauma like hypothenar hammer syndrome from using the hand as a hammer, problems with blood vessels, inflammation in the synovium, and even weird muscles in that area.
So how do you diagnose it?
It depends on the pattern of symptoms. If the symptoms match a specific zone, that's a clue. Another thing is that sensation on the back of the hand on the ulnar side is usually fine because that's supplied by the dorsal cutaneous branch, which branches off before Guillen's canal.
So sensation testing can be helpful.
Absolutely. We use things like Simmons-Weinstein monofilament testing and two-point discrimination testing. And of course, we'll check how strong those intrinsic hand muscles are.
And what about those specific signs we talked about before, like Froment sign and clawing?
If it's just ulnar tunnel syndrome, you usually won't see those. DIP flexion of the little finger should be normal, and they shouldn't have a positive elbow flexion test either.
So how do you treat it?
If it's not too bad, we might try NSAIDs, rest, a splint, and avoiding whatever activities are causing it.
And if those fail?
If there's a lesion, like a cyst, or the neuropathy just won't go away with conservative treatment, then we'll need to operate. We'll go in and release Guillen's canal and the deep motor branch of the ulnar nerve.
And what does that involve?
We usually have to release the nerve completely throughout the canal.
Okay, so it's a pretty involved procedure.
It can be, and if someone gets ulnar neuropathy after a wrist fracture, or if it just won't quit, we usually operate sooner rather than later. Got it. So we've covered cubital tunnel and ulnar tunnel syndrome. Is there anything else we need to know about the ulnar nerve?
One last thing, traction neuritis.
What's that?
It's a chronic pain condition that can pop up after procedures like carpal tunnel release or ulnar nerve transposition.
So it's a complication of surgery.
Yeah, essentially. It can happen because of scar tissue, problems with blood supply to the nerve, not fully releasing the nerve during the initial surgery, or inflammation around the nerve.
Ouch. What are the symptoms?
It's usually pain that gets worse when they move their fingers, or if you press on the nerve, and it's often a problem after surgery.
How do you treat it?
Sometimes we have to go back in and do another surgery to clean up any scar tissue or adhesions that are bothering the nerve. If it's from cubital tunnel surgery, we might do another transposition or a medial epicondylectomy.
And does that usually help?
It can, but unfortunately, if there's a lot of scarring, it can be hard to get complete relief.
So it's not always a happy ending? Sadly, no. And for really tough cases, we might have to do extensive neurolysis and use a flap of tissue to cover the nerve and give it a better environment to heal.
Okay, so that's traction neuritis. Any other pearls of wisdom you want to leave us with before we wrap up?
Just a few key things to remember. Always get a good history from your patient about their work and what they do in their free time. That can give you a lot of clues. For carpal tunnel syndrome, we usually use NCS to decide if surgery is necessary. And remember, conservative treatment for CTS doesn't always work. It can come back. Oh, and during carpal tunnel release, be super careful not to damage that median recurrent motor nerve.
Right, that's crucial.
Yep. And when you're trying to figure out if the median nerve is compressed proximally or distally, checking sensation in the thenar eminence is really important. If someone can't extend their index finger and they have paresthesia, think PIN syndrome. For stubborn cubital tunnel syndrome, you might need to transpose the ulnar nerve. And for traction neuritis, often you'll need to go back in surgically.
That's a lot of great information. Thank you so much for breaking it all down. This has been incredibly helpful.
Glad it was useful.
So, that wraps up our deep dive into nerve compression syndromes of the upper extremity. We've gone through a ton of information, but hopefully this has been a good review as you get ready for your boards.
It's all about knowing those anatomical pathways, where those nerves like to get trapped, and how those different syndromes present.
Exactly. Thanks for joining us, and best of luck with your studying.